All right, we are ready to go.
Hey, welcome everyone to our 2026 Revascularization Code webinar for lower extremity. Uh, if you're in the endovascular vascular disease space, I think you've probably heard there's big changes, and this is causing a lot of us excitement, but also a lot of anxiety as well. Not sure how this is going to play out. So, for that reason, SCAI is here to try to provide some insight, and we have a great panel here to talk to you this evening. So Monica Wright is our Director of Regulatory Affairs. She's got over 25 years in medical coding, billing, and practice experience, has been SCAI's Director of Regulatory Affairs for the past 4 years, involved deeply in the process of CPT codes, and it helps guide us through all of that. We have Osama Ibrahim here. He's interventional endovascular medicine and vascular medicine, and he practices in Tennessee and at the Vanderbilt Tuolumne Heart and Hospital, where he's the vascular service line director, also directs the vein clinic there for Cardiology and Vascular Associates in Tullahoma, Tennessee. So he's been very involved with our advocacy committee and also with the ACC Vascular Disease Leadership Council. And finally, we have Jeff Carr, who is a vascular endovascular specialist in Tyler, Texas. He's with the Heart and Vascular Institute there. Jeff has a long background in advocacy work. He's previously president of the Outpatient Endovascular and Interventional Society, been very active through the Cardiovascular Coalition trying to improve access to care, and has served with SCAI on our advocacy committee. And my name is Lyndon Box. I did introduce myself, but I'm former chair of SCAI's advocacy committee and SCAI PAC. So with that, I'm going to turn it over to Monica to, sorry, I need to acknowledge our support. We do have Boston Scientific, Cordis, Phillips, Shockwave, and Gore have been generous sponsors. And just want you to be sure that you're aware you do get one MOC credit and one CME credit. Those are available for participating in the activity. And ask that, if you will, to complete the evaluation at the end of the course to get your credits. So now I'm going to turn it over to Monica to talk to us a little bit more about the code changes and give us a general overview.
Thanks, Dr. Box. So for many of you, I'm sure you are aware there are major changes coming to the code set this year. And the most important thing is that everything you know up to this point is being replaced. Every code that currently exists in 2025 is being deleted, and the code set is being replaced with 45 new codes. This has been a long process to pull all of this together. It's been a collaborative process with multiple societies. I have to recognize the Society for Vascular Surgery for doing a lot of the heavy lifting on this and getting this code set through. It was, a collaboration. We worked together, and now we're here with the new code set, and wanted to give you the information so that you're ready as it comes out in January. Just a caveat, obviously, we don't know all of the payment answers just yet because all of the payers have not put all of their policies into place. But this presentation is going to go over what we know from the CPT book, what the codes look like, the purpose of the codes, and as we have more webinars in January, as we get some answers, we have a Q&A webinar for the last one. Hopefully we'll know more and be able to discuss it. To start with, the codes have been divided into 4 vascular territories. For the sake of time, tonight we're going to discuss the codes in the iliac and the femoral-popliteal territory, and then in January we'll have another webinar for the tibial and the inframalleolar territories as well.
All lower extremity revascularization interventions include the listed procedures. They should not be billed separately.
So when we look at the code changes for 2026, again, the codes are divided into the 4 vascular territories. And with the iliac, we have 3 vessels that are included in that territory: the common iliac, the internal iliac, and the external iliac. And we look at the old codes to the new codes. You can see that there are some, you now have 2 codes for every old code. The old codes had a one base code, and now we've broken that down into straightforward and complex. Now, these is kind of a summary of the code changes in the iliac territory. Again, you've got the common iliac, the internal, and the external. You can see we've got the base codes, which are for the initial vessel, which we'll look at a little bit closer. And then you've got up to 2 add-on codes that can be used in the iliac territory because there are a total of 3 vessels in the iliac territory. And then lithotripsy may be reported 3 times per leg. Now, these codes are meant to use the most complex service per vessel when more than one lesion is treated, because these are 1 code per vessel, not lesion. So you're not going to use add-on codes for additional lesions in the same vessel. And just to be aware that in the iliac territory, the atherectomy has a category 3 code. It's not included in this code set. It's 0238T. Now, in the primary or the base codes, we have
The new codes include both base codes and add-on.
apologies. I'm sorry, technical difficulties. Just 1 second while I get the the video back up. I apologize. So we have the primary or initial codes. Again, in the iliac territory, we have 2 interventions. We have the angioplasty and the stenting. So you've got the straightforward and complex base code for angioplasty and the straightforward and base code for the stenting. For the add-on codes, again, you've got the straightforward and complex angioplasty and stenting, and then there's an additional add-on code for lithotripsy. So if we look at the full codes, you can see the way the codes are structured. We start with the angioplasties, and then we have the straightforward lesion for the initial vessel, and then the add-on code right after it, straightforward lesion for each additional vessel. Then you go into the angioplasty, the complex lesion, initial, complex lesion, each additional. And then we move on to the stents, same thing, straightforward additional, complex additional, and then the lithotripsy codes. Now, what does straightforward versus complex mean in this code set? In this code set, according to the CPT book, straightforward is simply stenosis, complex is occlusion. So if there is any blood flow through the lesion at all, it is straightforward. It has to be a total occlusion in order to qualify for complex under CPT guidelines. The primary or base codes are the initial codes. You'll use 1 primary initial code per territory. So discrete lesions treated in separate territories may be separately reported. But again, interventions are reported per vessel, not lesion. So you're going to code to the most extensive service performed. So if you have a stent and an angioplasty done on different lesions in the same vessel, you'll code to the stent. And when you're dealing with the primary or base codes, if you have the same initial vessel code in both left and right, you'll use the modifier 50 to report it as bilateral. For the add-on codes, a maximum of 2 add-on codes may be used per leg in the iliac territory because there are a total of 3 vessels in the territory. So the add-on codes may be billed, each vessel, the appropriate add-on code up to 3. And then because there's 3 vessels, lithotripsy may be reported 3 times per leg. When we're looking at the add-on codes, though, because they are add-on codes, you will not use the 50 modifier if it's bilateral. You will add the 59 modifier to those add-on codes. Moving on to look at the code changes in the femoral popliteal. You've got the 4 vessels in the femoral popliteal region. Coding changes again how they look. We had 4 codes in the old set. In the new set, these are the initial vessel codes. You're looking at straightforward and complex for each. And so a couple of big things here with the coding for the femoral popliteal. Even though you have those 4 vessels, for the purposes of coding, the common femoral and profunda femoris are treated as a single vessel, and the superficial femoral and popliteal are treated as a single vessel. So there are only 2 vessels for coding purposes in the femoral popliteal territory. Again, you've got the initial codes. There's more initial codes in the this territory, which we'll look at. And then you get 1 add-on code for the additional vessel because there's only 2 vessels that can be reported. Lithotripsy can be reported twice per leg. And once again, use the most complex service performed when more than 1 lesion is treated. And do not use the add-on codes for additional lesions within the same vessel. So here in this territory for the initial primary codes for straightforward and complex, this time you have one for angioplasty, stenting, atherectomy, and then a combination code for angioplasty, stenting, and atherectomy. The add-on codes are the same. You have add-on codes, straightforward and complex for angioplasty, stenting, atherectomy, angioplasty, stenting, and atherectomy. And again, you have the lithotripsy add-on code. Here's what those codes look like. Again, you've got the straightforward initial followed by straightforward additional for each type of intervention. And again, because there are more codes, but same thing. Straightforward, straightforward, complex, complex, ending with the lithotripsy. The concepts are the same. You have the same coding concepts in every territory. You're going to use 1 base code per territory, 1 initial code. Discrete lesions may be reported with the appropriate primary codes in separate territories. Interventions per vessel, not per lesion. Modifier 50 for initial codes for bilateral. Modifier 59 for add-on codes for bilateral. Remember, in this territory, you've only got 2 vessels. So lithotripsy may be reported twice per leg. And with that, I will turn it over to Dr. Carr to give us some examples.
Dr. Carr, you're on mute.
Okay, sorry about that. Well, thank you, Monica. And I think, again, that was a really good introduction for half of the COSAS. We have the other half coming up, but really wanted to present here mine for a case of an iliac coding situation that is fairly common for what we see. I'll just take you through the clinical vignette here. Basically, it's a 68-year-old former smoker with the usual risk factors who's had several years of progressive left more than right buttocks and leg claudication as a Rutherford 3 type of patient. And he failed structured exercise training and silastazol, and his quality of life is impaired to the point where he wants intervention. He had ABIs at rest at 0.7 on the right, 0.55 on the left, and the duplex ultrasound showed reduced velocities that were biphasic in the right lower extremity, monophasic in the left from the common femoral artery down. The lower extremity arteriogram, and I don't show pictures here, but I'll just highlight really the targets of what we plan on intervention with the asterisk here. There was an 85% severely calcified right origin to mid common iliac artery, and there was mild to moderate plaquing through the remaining iliac, common fem, down to the pop. On the left side, he had a 70 to 80% moderate to severely calcified mid to distal left common iliac artery. And that lesion ended just before the bifurcation of the internal and external iliac arteries. So there's a normal spot there, but it was very short. Right at the origin of the left external iliac artery, there was a chronic occlusion. It was 4 centimeters long. It also had significant calcium, and it was just patent. Just distal to a patent internal iliac. So right at the origin, there was moderate to severe plaquing in the left common femoral artery, about 40 to 50%. And from the SFA to the pop, it was pretty okay, normal. Below the knee, he had bilateral PT occlusions, but two vessel runoff through patent anterior tib and perineals. So kind of a typical iliac patient with claudication. And so since we did the diagnostic from the right common femoral, yeah, we attempted to access to the contralateral side first, but that failed because of that origin severely calcified right common iliac artery lesion. So came back and treated the right common iliac artery first with a balloon angioplasty. There was some dog boning, not unexpected for the severe calcium, and the balloon ruptured. That led to IVL, intravascular lithotripsy of that right common iliac lesion, and it yielded. And then put in a balloon expandable stent from the origin to mid right common iliac artery with good results. Went over, crossed over for a contralateral access to the proximal left common iliac artery and tried to cross antegrade through the CTO, the left external iliac, but that failed due to really densely calcified proximal cap, just despite some wire escalation. So that led to switching to the other side. So jumped over and accessed through the left common femoral artery with ultrasound guidance. And there was a good landing zone at the distal portion for the sheath at the distal portion of that left external iliac. So of course, retrograde was successful, as it often is in these dense calcified lesions. And we're able to cross that left external iliac artery, do balloon angioplasty with an 8 millimeter balloon of the common iliac artery and a 7 millimeter balloon ultimately of the CTO of the external iliac artery. There was some residual obstruction, however, didn't yield well with the POBA, so we used shockwave intravascular lithotripsy of those two lesions, the left common iliac and external iliac arteries, and they gave. That led to a single self-expanding stent that was placed from the mid to distal common iliac artery and extended through the external iliac artery to complete the procedure after completion balloon angioplasty for both areas. So I thought this would be helpful to just bring a table to summarize what Monica had introduced, at least for the top two, these 4 different territories with the new codes. And we can see on the top the iliac, and I'm going to apologize that there's a typo there. It's 37254, not 524, but those are the code sets for the iliacs. And so there are 3 distinct vessels, as Monica said, the common iliac, the external iliac, and the internal iliac. And this is just for coding purposes. And as I've kind of digested a lot of this, I really think it's helpful to think from a coding standpoint and not an anatomic or a physician standpoint when we kind of digest some of the nuances of how we bill here. And of course, a lot of people are really interested in the RVUs and the payment changes that happens, and that happens because of these code sets. And they're really based on all these CPT codes. And every single code has a vignette and the practice expense inputs that go into making up the fee from CMS that serves the basis for this and also yields these RVUs. And overall, there are reductions across all the codes for most of the straightforward, not all of them are reduced, but most of them, there's going to be a decrease in RVU and raises for the complex. As Monica had mentioned, the complex meaning any occlusion. And those occlusions could be, 10 millimeters to 40. It doesn't, 400. It doesn't really matter how long they are. It's occlusion or not. the additional vessels in the same territory in the past code sets, our current code sets, are usually paid at about 50% of the initial ones. And those, you'll see these additional down here below on these examples, the additional add-on codes really kind of hold steady. They don't really change a whole lot with the RVUs. So although we see a marked increase, and you'll see in green down here of the different category, of the different major ones that we use for the iliac for PTA and stenting, straightforward and complex, you'll see again in red a slight reduction for the straightforwards and a significant raise for the complex, but also really kind of holding steady with the additional or the add-on codes. So going back to my case, wanted to kind of walk through what we think, as we digest what the booklets tell us to do here. You want to bill your first, the initial artery as the most complex service that is provided for the vessel that was treated. So as I had presented, there was a CTO, and so that it gets us the complex code. And it will serve as our initial artery treated, or some people call it the base code. After that, we did a balloon angioplasty and stenting of that iliac, that external iliac, and it was a complex. So there's a code there. That initial code is a 37260. I'm sorry, we did intravascular lithotripsy with that, and here's our first intravascular lithotripsy code at 37262. The second vessel was on the same side, the left common iliac artery, and this becomes an additional vessel treated because remember, there are 3 vessels in the territory. And so we put in a 37255, which is balloon angioplasty alone of the iliac. That was a straightforward because it was patent. And that's an add-on code. Notice that I stented that as well. We stented it in this vignette. And we'll talk about this, but we build this as a balloon alone here because it was a separate treatment and a separate lesion in a separate vessel in the same leg. We also did lithotripsy on that, so it gets a 37262. And then finally, the contralateral leg, the right common iliac artery, is also an additional vessel treated because it was a straightforward. And this is an add-on code as a 37259, but we put a 59 modifier on it, as Monica had mentioned, because it's a bilateral vessel. It's a bilateral code. So that tells them that this is the other leg for that. It also had lithotripsy, so we put a 37262 to get to the full total of 3 that are allowed for the iliac territory when it comes to the IVL codes. Well, what does that mean for work RVUs? These are the published RVUs on the Medicare website. And so these work RVUs come down to, if you look at the first vessel, the initial artery treated, the 37260 is a 12.69 RVU for a complex. The IVL is 3. The second vessel, because it's an add-on code for balloon angioplasty only, is a 37255. We'll have 3 work RVUs assigned to it. Again, a second IVL. And then the third is the right common iliac artery is the additional vessel. It had balloon angioplasty with stenting as an add-on code in a straightforward vessel treated as a 37259, and it gets 4 work RVUs. But again, a third intravascular lithotripsy treatment for 3. So a total of 28 and 69 work RVUs for that procedure. Notice that we had stented the external iliac artery, that 37260, that CTO, but it was a self-expanding stent that crossed the other vessel territory. And not territory, but the other vessel, sorry, it's the same territory, the other vessel to the common iliac. So it was one stent that was used for both, which is why we did not apply the add-on code for the second vessel to include stenting. We did, however, use a different balloon to treat a distinct lesion within that left common iliac artery, and therefore we coded it as a 37255 for balloon alone, straightforward. There's a lot of nuances as we can maybe discuss later on with these kind of situations, and we have to interpret, the language that are printed in the code booklets here the best we can. And so, as I mentioned about the payment changes, this is the entire code set, the kind of the major straightforward and complex. These are not the add-ons, but the main initial ones, just to give you a comparison between 2025 and 2026. Again, red showing reductions and green showing improvement. And Osama's going to, take us into the Fempop side of this story here, but I just want to introduce the advancement in many of these codes. And of course, the inframolecular that didn't have any assignment or payment in our current code set does have, RVUs attached, as outlined here below. A lot of people also have asked about what's the impact going to mean in terms of your total business of how you do it. And if you think more globally, this is actually data and an impact analysis that was done by one of our advocates. And it was based on case mix complexity. And basically, if you make assumptions about the case mix that you do currently, and the volume that you have in currently, say in 2025, what could we expect an increase in revenue potentially with proper coding? And again, this is not hard science, and this is basically taking existing data that you have and applying the assumptions that are actually published in the final rule from CMS. So CMS used these case mixes, as I'm going to illustrate here for you. If you take the iliac cases that are done and you say 85% of those iliac cases are straightforward and 15% are complex, meaning CTOs, then you could see a net revenue increase of 30% based on the new code set changes. For a Fempop situation, if you assume 70% might be straightforward and 30% complex, you see the revenue changes over here on the right there. Same thing for the tib perineal. Again, tends to be more CTOs below the knee. You have a 50-50 mix, you would expect a net increase revenue of 14%. And for the inframolecular, we didn't have any revenue, but you can possibly say there would be 50% straightforward, 50% complex. That's just new revenue. And none of this factors in any reimbursement for the intravascular lithotripsy, the additional vessels that we talked about, and any other adjunctive procedures that are routinely done in these procedures. So we just wanted to give, a lot of people are very interested in the analysis. You can do your own with your own volumes and your case mix. Of course, everyone practices differently and has different types of patients in their practices, but it just gives you some sort of a directionality as some of this reimbursement starts to come out in what we might expect in the near future in 2026. I think Monica had told us that SCAI has published this cheat sheet for the coding. That's very helpful as you get started. The code sets, those were deleted. And I'll end it there. These are just some summaries of some of those changes. And so thank you, and I'll hand it off to Osama to take us further down the leg.
All right. Well, thank you. Thank you, Jeff, for your detailed conversation. And thank you, Lyndon, for the introduction. And thank you, Monica, for your long journey with this. It's been a long, long time. My name is Osama Ibrahim. I am an interventional cardiologist and endovascular medicine specialist, and I'm here to discuss the CPT changes for the Femoral-Popliteal segment. And similar to what Jeff had just talked about, it is fascinating to see that this is clear as mud. And unfortunately, it is going to continue to be an area of discussions throughout 2026 because we can only imagine the amount of confusion that this can relate not only for us as physicians and our coders and our billers, but also for the insurance companies. So there's definitely more to come on this. Now, the Fempop segment, as we all know, historically is the higher area of procedural volume. Obviously, it was a large area of contention where all societies were involved in this. And actually, this was driven primarily by SVS that did a phenomenal job on our behalf. And obviously, SCAI, ACC, SIR, and several other societies were involved to try and get this code set to where it is, which to some extent does reflect some of the exceptional work that we do. The new concepts, as Monica had said, is right now we're dealing with almost, yes, they're 4 vessels, but 2 segments. And these 2 segments are primarily common femoral profunda and SFA-popliteal, which we used in the past was all bundled in one code. So this is a very welcomed addition. The question is that how are we going to get used to, and our coders getting used to really capturing the codes for this. The next concept is the straightforward versus complicated. Now, there was a lot of forth and back in the discussions between the CPT advisors and the CPT panels, and it came down to the end that basically straightforward means there has to be a straightforward is stenosis. You cannot get a no matter how much you want to describe the vessel, heavily calcified, you're using all kind of different toys and tools and bells and whistles and distal protection. If there is no occlusion, no matter, even if it takes 3 hours, it is still going to be straightforward. Complex means there's an occlusion, as Jeff had mentioned, even if that occlusion is 10 millimeters versus 400 millimeters, it is going to be still considered complex based on the fact that it's a total occlusion. So please, in the past, when there were all these modifiers that you can put on for complexity and all that stuff, here, straightforward means stenosis, complex means occlusion. Please stick to the narrative. Otherwise, there's going to be a lot of headaches. As we know, the Fempop segment, there's pretty much most of our toys and bells and whistles are in here. There's a lot of areas of what we can use there, but at the same time, it really comes down to understanding these codes a little bit better. Monica did a phenomenal job at the beginning, kind of giving us an oversight. So the 37225, 37226, 37227, which we were used to now is replaced with similar codes, but straightforward and complex. The new kid to the block is basically the additional, which is additional angioplasty, additional atherectomy, and additional atherectomy and stent. Please stick to the narrative, which is common femoral profunda is considered one segment, SFA and POP are considered one segment. You cannot do SFA POP and use 2 codes. It doesn't work that way. It's common femoral profunda that's considered one segment, and the other segment is the SFA and POP. This obviously SCAI has this on their websites, and obviously will be available to each and every one of you. However, please read these codes, understand when to use these codes, but also with new code sets means that you need to, in your dictations, to be extremely detailed, to tailoring it to what the coders want to extract. Because if you've done the work, but you didn't document it in the right way, it never happened. So obviously, I get a lot of nasty calls or nasty emails from our coders, which basically, what did you do? How did you do it? Please put it in a way that we can read it. And obviously, they're doing it for our sake because you can do all the work, but if you're dictating it wrong or dictating it insufficiently, then you're going to have problems. And obviously, with all the kind of excitement that's going on in this field, everything's going to be emotional, excitable, and your billers are going to be doing that, your coders are going to be doing that, and obviously we haven't even talked about the insurance companies yet. All these are on the SCAI website or easily available, and obviously through the chat, they can show you the link to these. These are the RVUs that are associated with it. Now, most of us interventionalists do a lot of work within this segment, and in the past, you notice that actually, as Jeff elegantly showed in that slide, there is a potential 25% revenue increase for your practice if it's captured accurately and captured correctly. For the sake of us trying, instead of going through clinical vignettes and codes, as we said, this is a common femoral artery lesion, short segment, heavily calcified, eccentric lesion involving, the SFA profunda bifurcation. This to them is considered straightforward. So please understand. I mean, we can look at this and in your dictation, or when you're looking at an angiogram and you cringe, you're like, oh my God, this could, shower down. This could be, we're going to need to spend a lot of time with IBL, directional atherectomy, whatever tool, bells and whistles you're going to use. You're definitely going to use distal protection. This to them is straightforward, right? So please, you have to make a clear distinction about what in your head is considered complex versus what they're looking for. This is considered straightforward because, as Monica said, that there is complete cessation of flow in that vessel segment, right? This next case, this is complicated, obviously. There is a very eccentric lesion. The top kind of CTO, there is nothing communicating. This is considered complex, right? So please, it's all about understanding what the code sets are. This is considered a straightforward lesion because there's no occlusion. It is diffuse, it's dissected, it does not look pretty, but it is considered a straightforward lesion to them. So lesion A, the one on the left, this is a straightforward, and this is something that, yeah, this would take a few minutes. You can treat this in several different ways. Lesion B is not the case. I mean, obviously there's multiple islands of CTOs, a lot of collaterals, you might need to go antegrade, retrograde, however you want to do it. But those are the kind of things where you have to, in your description of the lesion. Now, remember, we're looking at the angiogram, but in a note, this is where you have to be very specific with your buzzwords. Otherwise, you are not going to be you're not going to have the suffice documentation to support to achieve such the complex code, right? So that's where you have to put a little bit more time and effort in there to try and get to the level of these complicated complex codes. This is considered the straightforward because there is a very minimal channel of flow with contrast. So these are the kind of things that would be extremely helpful. Monica was nice enough to share with us some of the modifiers. But again, this is definitely a complicated, complex SFA pop lesion. Yes, this is one territory, not because it's in the SFA and the POP means they're two different codes. No, remember, it's SFA and POP is still bundled. Common femoral and profunda are considered bundle. So please, just make sure that when you're in your dictations, just to try and really elaborate what you're seeing, because they're not looking at the angiogram, you are. This is a nice summary by SCAI about the various areas. And both, they can find, both for iliac and the SFA pop. And I understand in January, there's going to be one for the below the knee and the inframalleolar. Thank you very much.
Those were some great cases and walking us through sort of the nuts and bolts of how to apply this. We've been getting a number of questions in the chat, and I think we've been trying to answer those as quickly as we can as they come in. So if you don't have your chat open, you may want to just take a look at some of what's already been answered, but would really open it up to the audience if you have anything you'd like us to answer live.
Hey, Linda, while they're doing that, I kind of wanted, it struck me when you were talking, Osama, about complex, describing, and we would see this through our physician's eyes that a case is complex, and I know many of us will actually put the word complex in our dictations. This is a very complex case, or we did a complex lesion or whatever in your summary. I think going forward, that may be something we have to be careful about with different coders. Coders are not physicians, and I think there could be some many cases, many things could be misconstrued because of our terminology and getting used to this new terminology, straightforward, complex. Of course, there's misnomers with straightforward, as you mentioned, but that's the way it is. And there's a long history of why it's like this now, and it's the best we could do. But I think there's some word of cautioning about how we change our dictations. As I've been digesting this, I've been even thinking about how I'm going to modify come January 1, how I'm going to modify how I document. Of course, it's all supported in the document. We really want to highlight to the audience as well. The better your documentation that's aligned with this, probably the more successful you and your business place will be in getting the best, the maximum reimbursement that's due. So I just want to throw that out.
Yeah, and that's why I brought it up, Jeff, because we're used to using the word complex, or I mean, we rarely use straightforward in our dictations, but we always use complex, right? I mean, even with the atherectomy battle, we always used to say, this is a complex lesion, circumferential CAT-SUB, 360-degree, all that stuff. Now,
Sure.
please be very cautious, as Jeff said, not to confuse your coder or your biller. Because ultimately, if it's a straightforward lesion and it's billed as a complex, it's going to come back to bite you.
For sure.
And it might delay billing and red flags and all that stuff. And again, I'm really curious to see how long this is going to delay some of the revenue cycle for these billings, because it's going to be very, very tricky. And unfortunately, it's work in progress. It's going to be painful, but at the same time, I think it'll be interesting to see. I mean, obviously, SCAI will keep us in the loop based on some of the feedback they get from their membership.
Yeah, for sure.
I have a really good question that came in on the chat bar. So there was a question about diagnostic angiography coded at the time of the intervention if they've not had previous imaging, and mentioned that the understanding was it had to be a diagnostic angiogram performed from a different access site. I was not aware of that change, so that's something I wanted to confirm if that was the case, or can you still, do your diagnostic angiogram from the same access that you also ultimately intervene from if they've not had prior imaging?
So I can say, from what I understand, the code changes are only for revascularization. They're only for intervention. That's really important to keep in mind, because we think about other things that are done, ultrasound guidance, or other adjunctive type of things that we might do that we still bill for. And so, it's nothing has changed from the diagnostic codes as I understand, and the same principle is there. If you have a planned intervention with a previous angiogram, you really cannot bill for diagnostic angiography with that intervention. If you have a reason that if something has changed clinically, and you need to do a diagnostic in order to verify that there's not an interval occlusion or thrombus or something happened, and you do a diagnostic angiogram as a part of that intervention in the interim, that's justifiable, and there is payment coverage for that as long as you document the purpose in your notes.
Thank you, Jeff. I had a question about as far as if you have an unsuccessful intervention, so you try to cross, you're not able to cross, how does that end up being coded out?
I'll jump in. As far as I understand, it's the same. Again, the same thing. If you fail an intervention, you can only bill any diagnostic codes that are there. Again, unless you just have a diagnostic, and then you probably shouldn't bill. I don't know if you can bill two diagnostics if you failed in an attempt. You can document an attempted intervention. It depends on your payer, I would think. But as far as I understand it, please correct me, Monica, if I'm wrong. From Medicare standpoint, if you do not perform an intervention, there is no coverage. You can't code an intervention. You can't, if you don't blow up a balloon inside of a lesion for balloon angioplasty or do any other intervention, even if it's unsuccessful, if it's unsuccessful, if you can't cross a lesion, but usually it's CTOs that we run into that, where you don't do anything and you just try to cross and cross with CTO devices, upscale, that's wire escalations, all these techniques we do. And if you're unsuccessful and do nothing else, you cannot bill for an intervention or attempted intervention, as far as I understand. Would you
Yes,
agree with that, Monica?
yes, I believe that is correct. I was just looking, I thought in the introductory language they said something about it specifically, but I haven't found it. If I locate it, I'll let you know.
Thanks. Trust but verify.
It's a small amount of money, but I was also under the impression that you no longer were able to bill for ultrasound guided vascular access. Is that correct? That it's been bundled in now?
I'm not aware of that, and I don't know
Yeah.
it's true. I remember reading that other
Everything stayed the same.
do is still the same. If it's basically including IVUS. IVUS has not changed for this year, and that's a diagnostic procedure. Again, these are revascularization codes. They have nothing to do with any diagnostic or IVUS or imaging codes. So all SNI and imaging codes stay the same as they were in 2025. It's just revascularization codes, one that we're talking about. Again, please check me. I'm not a coding expert, but I did learn that.
No, I was not IVUS. I was talking about ultrasound for access.
Ultrasound guided
Oh,
access, the same thing. It's a diagnostic
okay.
image, or it's not an intervention. So it falls in the same way that there's no, again, please check me, Monica, and others if we can. Again, this is a learning process about all of these changes, but what I understood is none of that has changed for the peripheral space, for the lower extremity space.
So
Yeah,
there is
Jeff, you are correct.
imaging. There is imaging included in these codes, but I do not believe this verbiage changed from previous. The imaging is for intraprocedural guidance, including radiologic supervision, directly related to the intervention performed, to document completion of the intervention and to document completion of the procedure. That's the imaging that's included.
And that's built in the payment. Everybody should know it's not just the intervention. There's a payment that everything gets attached that you do in that procedure based on the vignette. So you do the first diagnostic imaging where you just do your first angiogram before you intervene and you do your completion. That's all bundled into the procedure. That's the intervention payment. The other thing I would point out too is there's bundling as much as we've advanced codes, the number of codes. There is bundling. So before it was a balloon angioplasty separate code, atherectomy separate code, and stenting separate code. Now, if you do atherectomy with a balloon, it's balloon and atherectomy. It's one code. And same with stent. It's stent and balloon. Balloon angioplasty and stent. So it's bundled into the payment and the vignette that we talked about. Those things that lead to these CPT codes. It's bundled in for the payment. And while we're speaking of payment, one of the positives that we have with advocacy is to include drug-coated balloon in the vignette. And that was very important because, as in certain settings, there is no payment for drug-coated balloons. And it's baked into the payment for an SFA pop intervention. And actually, they originally had it as one drug-coated balloon. And with advocacy, we were able to get to argue for two because of the length of the lesions treated on these straightforward lesions are complex.
So I think you went through this kind of in your explanation for the case earlier, but just to recap a little. So let's say you do an intervention and you explain the crossing the external iliac, common iliac, and how that might play out. What if you did pretty complex work, and this doesn't happen often, but it does in the peripheral space, where you do say a Fempop lesion, come back and do external iliac, common iliac. Is there any limit as far as, if you move to a different, you said you could bill for 3 in the iliac codes because there's only 3 vessels there. But I'm assuming if you go lower, that's a different set of codes, you would be able to bill those as well.
Yeah, and just to bring the terminology, that's correct. It's called a territory now. We didn't have that word before. It's a separate territory, and Monica, correct me if I'm wrong, but I understand that you could do an initial code in a new territory. Right, Monica? That's how we were interpreting the language there.
Yes, but it should be if it's one intervention, it's coded once. So you would have to be a separate balloon to be able to bill it.
Yeah, but I mean, a whole different territory is what he's asking. Really, a multi-segment disease. So you're in the iliac and you go down to the popliteal, all in one procedure in the same leg, but 2 different territories.
If
Yeah,
it
it's
if it's
territories. Nothing has changed there,
right,
Jeff.
but
Nothing has
if it's
changed. Yeah.
treated with one intervention, then it's one code. It doesn't matter if it crosses territories. If it's one lesion, one
No,
intervention,
no.
you only get one
Yeah,
code.
yeah.
So I did want to answer one of the questions on there. How did SCAI advocacy affect the coding? Because I love to get to answer this. SCAI, so I finished my time on the advocacy committee about 2 years ago. We were already involved when I was on the committee at that time with Monica, who is our representative or director, but also with our representatives. We have SCAI members that are part of the CPT committee who were involved with members from the other professional societies involved from the beginning of these discussions. So SCAI is very intimately involved in advocacy for interventional and vascular specialists with the development of any codes that affect our specialty, but in particular with these codes.
Yeah, this code set, this CPT for lower extremity revascularization has been about 4 to 5 years at least. In how many cycles, Monica, at least numerous. I
Yeah.
mean, it's been ridiculous. And advocacy from several different societies, including SCAI, ACC, SIR, and SVS. SVS actually did a very decent job of leading this, and each society did a lot of heavy lifting in this area to get this end result. Of course, we asked for much more, but we're happy with where this got to. It's just a little, as I said, clear as mud, but it's much better than it was before.
And just to go back and clarify a previous answer, thank you to Carrie for finding it in the CPT book. It specifically says a procedure that does not result in successfully crossing a lesion is considered a diagnostic procedure and is reported using the appropriated catheterization and diagnostic angiography code. So there it is on page 315 of the code book.
Thank you for keeping me honest.
We have a question about deep vein arterialization. I'm not aware that that has been addressed in this code set, but maybe others could speak to that.
No.
It has no specific codes. No, it's still considered a Fempop revascularization, just an expensive one.
Yeah,
Right, Monica? I don't think they have separate codes yet, right?
I think it's still a category 3 code.
Yeah.
Yeah, and to kind of jump in on that as well, you notice too, there's no IVL reimbursement for below the knee approved here for this. So,
That was one of the questions earlier by Shadi.
and we'll talk about that on the next webinar, but it is, they don't recognize that. Let me take any more questions there.
We have one about modifier 22. I can speak to that, or if others want to speak to it. I don't think that's gone away, but I don't think it's any more effective than it used to be, is my understanding.
Correct. Modifier 22 can still be used for procedures that go above and beyond with the same documentation requirements and everything that they've always had to try to get that additional payment.
I think the experience I've had with modifier 22 is it makes me feel better, but I often don't get paid for it.
That's very true.
But I at least feel like I asked.
So we're getting a couple of questions about bilateral, and I know this came up in Dr. Carr's example, and it is a little confusing with how things are done. The one question is, if Fempop and tibial arteries are treated, can we code initial codes for each territory? And the answer to that is yes. And each separate territory, you're always going to start with one initial. But once you've got your initial in each territory, you go to the add-on codes. And this is where the bilateral gets tricky because on page 315 also in the guidance, it says when the same treatment in an initial vessel is performed in the same vascular territory of both legs in the same session, append modifier 50 to the initial vessel. So you get initial if that's the most complex procedure that you're doing and it's done in that vessel in both legs. You would use the initial with the 50. But then it goes on to say, when treatment in an additional vessel is performed in the same territory on both legs in the same session, report the add-on code for the same treatment, the additional vessel twice. So if it's not the initial code that you're billing in that territory based on the complexity, et cetera, then it does drop to an add-on code in that same territory, and you will use the 59 to denote it's a separate leg. So that's how it's worded in CPT. We'll have to see how it plays out with payment and with the insurance companies. But yes, it is a little confusing. But you do get one initial code for each territory that is billed on that day.
Again, just to highlight the word vessel and use vessel based on the table, based on what Monica presented as the definition. So what's a vessel? They define them very clearly. And that will help bring clarity as we interpret these.
Well, I think we're getting close to the end of the hour. We still have some good questions coming in, and we do have another webinar coming up that's going to focus on below the knee and the codes that are new and different there. And then we have I think a fourth webinar as well, Monica, that's going to be sort of a chance to come back with answers to things we didn't know at this time, and also answer any lingering questions people may have. So really think this was great. I learned a lot, even though I thought I understood how this worked. I realized that kind of like Osama said, there's a lot that's not clear just yet, and more will be revealed. But I think it was an extremely productive session. I really appreciate Jeff and Osama and Monica for the effort here, and appreciate all the people that came and joined us this evening, and hope you'll come back for the next webinar.